So this is the cover of the brochure from the first Transition Conference in 2000, Transition 2000. I had great ideas about this conference and where we were going to go with it. It was timely. It was the beginning of the 21st century, and this was an important need. And I put together an advisory board, and I had a family medicine physician on the board and many other representatives from different disciplines. And at the first meeting, about 20 minutes into the meeting, the physician turned to me and said, to the group as a whole, he said, what transition are we talking about? And so I thought, wow. So we've come a long way since then. So this is the attendance at this conference. We're over 200. That's our target, 200. The fire marshal says we can't have more than 224 at any time. So we try to, I have my city councilman here keeping his eye on me. So we're okay. And then those are the blue lines. And then the deep blue lines represent the live broadcast audience. So this is being broadcast live by TV signal by our team to 39 sites in the United States and Canada, and we have over 500 registrants. We've had over 500 registrants. And then there's a rebroadcast of this to their state agencies. So for example, several years ago in Alabama, we broadcast to the site in Birmingham, and then they rebroadcast it to all the Title V agencies throughout Alabama. And so what we know here is there's over 500 registrants, but we have no idea what the reach is. We had no idea how many people actually saw the broadcast. So we've grown in that regard. And this is a credit to our collaboration with the AUCD, the Association of University Centers on Disabilities. This has been a 6-year relationship where they have supported this broadcast. So Ben Kaufman, I don't know if you're here in the audience, Ben, but I want to thank the AUCD for their longstanding support of the broadcast. And we've also been represented across the United States. Here you see the United States map, and there's a star in every state where we've had a speaker. We've had speakers from 29 states. So this truly does not just have a broad broadcast audience, but we also wanted to represent, clearly this is focused in Houston and the Texas Medical Center in Texas, but we've tried to represent a broad reach in the United States. And we've also been blessed to have our speakers from the international audience from Canada. We've had, of the 20 years, we've probably had speakers for 10 of those 20 years from Canada. And E.L. Cohen is one of our speakers who's sitting here this morning, is from Toronto Children's Hospital, and from Europe. We've had international content experts. So we're very pleased that we've been able to attract the quality of the speakers. And in part, we're able to do that because of the support that we've had. Baylor College of Medicine, Dr. Mark Klein is my chair, has been implicitly and explicitly supportive of what we do in transition. He knows that this is a priority for the department. And he knows that it's important that pediatrics collaborate with adult medicine and make this as seamless a transition as we can. Texas Children's Hospital has also been a supporter for 20 years, and especially in the last 7 years, where they've provided explicit and implicit in-kind financial support and otherwise. And I want to thank specifically Gail Parazinski. Gail, if you could raise your hand, and Dan DePrisco, if he's here, our Executive Vice President and sponsor, is that they have made this a priority at Texas Children's Hospital, and we serve on an executive team that oversees the facilitation of transition between Texas Children's and Baylor Adult Medicine, and Gail and Dan and I are pleased to serve on that committee. And the Robbins Foundation since 2012 has been very supportive of what we've done. Mary Jo, if you could just raise your hand and be acknowledged. Mary Jo and her husband Bill have been supportive of the conference, and the ability to bring speakers from all over the world, from all over the United States, is in part related to the support where we can call people 9 months or 6 months in advance and say, we need you to come here. The people who speak at this conference are booked oftentimes well in advance, so we're able to book them for this conference because we know in advance we have support. I've mentioned the AUCD. We've had support from HRSA and the Maternal and Child Health Bureau, and some of our other supporters are represented here. And I want to thank the speakers. The speakers have come here and presented content that's been state-of-the-art. And what you'll leave here, for those who have come for the 20th year or the 15th or the first time, you're going to leave here with a lot of content. And what you'll see in between the speakers will be a rolling list of all the speakers for 20 years. I want to thank Loretta Collins for doing this, but it's a long list. I initially was going to show it during my talk, and I thought, I don't have enough time. But you'll see the people who have spoken for 20 years rolling, and their photographs, or some of their photographs. So thank you to all the activity faculty. And the faculty have included, from the beginning, families as experts, young adults as experts, and siblings as experts. So in the first year of the conference, on Friday morning, we had families, we had young adults, and we've had siblings off and on here to speak. So we know it's a principle in transition that you have to collaborate with families, young adults, and siblings in the network. And we've manifested that from the beginning. We've had family and sibs here so that the professionals would sit in the audience and really learn from the content experts. So this is we also were committed to manifesting the breadth of a young adult with chronic illness and disability, simply that they weren't defined by their chronic illness. And so we had an art competition in 2007, and it was adjudicated, where we had art faculty from a couple of the local universities. They came, and I think we had about 20 entries the first year. And the judges voted and the audience voted, and this was the first place winner. It's called The Gathering. It's by Romero Bermudez, and I bought this, and I have it hanging over my desk, and it's a reminder of, at the time, I didn't realize how poignant it was, is that this is the gathering. This is the gathering. This is us. This is what we do when we come together every year for this annual conference. And the next year, we had an art competition. Actually, the reason we don't have an art competition anymore is that it got to be so complicated. It was taking up as much time to plan the art competition as it was the conference. So we unfortunately let that fade away. But the second year, in 2008, we had a competition, and we voted, and there were winners. And I got up on Friday morning and announced the first, second, and third place winners. And the first place winner came up on stage, got the award. The second place winner, I called her name, and she didn't come up. And so we went on to the third place winner, and we went on with the meeting. So about halfway through the second talk, there was a woman who came up in a wheelchair with this nice baby blue suit on, and she had a couple of people around her, and somebody came up to the stage, and they said, Dr. Hergenroeder, this is the award winner for number 2. So we stopped the presentation. She came up, and she was helped by her helpers to come up to the stage. And the blue suit she had on was bought by her attendants the night before. So we realized that the conference had become something more than science and program, and it was about the people. And so I've been inspired by that. And as we come together and we talk about what this conference and what the field has been over 20 years, I'll never forget that. So one of the moms came up to me about 5 or 6 years into the conference, and she said, I've been coming to this conference for a couple of years, and what I've learned here saved my son's life. And specifically, she was referring to presentations about insurance, and in particular, Beth Suffian and her presentations about how one could build a plan to extend insurance. And this was before ACA. And she said, you saved my son's life, because we had no path forward. Ivy Goldstein, who's sitting here, we're also going to roll the comments of people who sent in their comments, so that they'll also be rolling. Ivy Goldstein, a parent of a teen with significant medical complexity, attended her first transition conference in 2007. I'm reading from what Ivy wrote. What an exciting, enlightening experience. We learned so much and left energized to meet with our legislators to tell them how difficult healthcare transition was, and they were listening. They were listening. I returned to the conference in 2008, and since 2010, I have attended in person or by broadcast every year. And 11 years today, October 24th, I interviewed and was subsequently hired by the Texas MCH Title V program and returned to work full-time for the first time in 18 years. What a great story. So we've had effect beyond what the immediate effect is of what we share scientifically and programmatically here. So what has happened over 20 years? I was chair of a committee at Texas Children's where we were building our infrastructure for transition. We sent a survey around to the medical chiefs of service, and these are some of the representative comments that represented the mood at the time. Parents don't want to leave pediatric care, Texas Children's Hospital. Even if we continue to see them for their medical specialty needs, we would like them to have an adult PCP, so a stumbling block. I'm worried that patients who have serious disease will be lost to follow-up. But the thing that was most satisfying to me is that the 85% at the bottom, they wanted help. Yes, there were barriers. Yes, it was difficult, but they wanted help. So that allowed us a window to say, we are going to be here and we're going to help. So that's where we started. And I was a speaker at this conference in 2003, and I was invited to talk about transition, but many people came up to me at the conference from the United States and Europe, and they said to me, yeah, I know you're talking about transition, but we don't transition our nephrology patients because the morbidity and mortality is too high. We think it's too risky. So this was in 2003. And part of the issue was represented in those comments. Part of the issue was, well, there's nobody to refer to. The adults don't want to take our patients. And then the second bullet I have here is that I think in the rearview mirror, we've come to appreciate a methodologic bias. Much of what was being written in the beginning was being written by pediatricians. I'm a pediatrician. And I think over time, what we've come to realize is that as the adult provider voice has become more prominent, nobody's more capable of taking care of complexity than internal medicine physicians and adult physicians. They're great at taking care of complexity. But there's nuance to this notion of the relationship between pediatrics and adult medicine. And I'll talk about that a little bit later in terms of what has changed. Part of what's changed is chronic illness and disability affects 1 in 5 families in the United States. So this is not a minor problem. And this is also not a project. When you go back home and you're advocating for support from your hospital and from your clinic and from your medical school, this is not a project. Transition isn't something that's over here. Healthcare transition from pediatric to adult-based care. This is medical care between mid-adolescence and early adulthood. This is medical care. We can't partition this out somewhere. This is mainstream. This is part of life course. And we have to treat it with all the priority that we do neonatal care, pediatric care, and geriatric care. This is as important as any phase in life. So what's happened over 20 years, parallel with this conference? Survival and life expectancy have increased dramatically. And tomorrow morning, you're going to hear from Brendan Lee. He's the chair of genetics at Baylor College of Medicine, an internationally recognized expert. And we've had profound change in the treatment and survival of common childhood conditions. And I've listed 6 of them here where, for instance, in congenital heart disease, there's more adults with congenital heart disease now than there are children with congenital heart disease. So there's been dramatic successes. And what Brendan Lee's going to talk about tomorrow is gene therapy and the revolution that's happening in neurologic disease and other disease processes where medicine is being revolutionized. So the conference that we're having today, 20 years from now, we'll be talking about conditions that right now had as dismal a survivor survivorship as did diseases 30 years ago. So we are charged with keeping pace with our other scientific colleagues, because there's going to be people that need us to transition. But as much as there's been tremendous advances in survivorship into adulthood, we have not been able to keep up with the vulnerability that young adults experience when they transition to adult-based care. And here I've listed 5 disease processes with their references. And there's morbidity and mortality if healthcare transition is not planned properly. Even when it's planned properly, there can be difficulties, the natural history of the illness, other factors. But this is a vulnerable period. So we need to build on the work that pediatricians have been successful in and the adult community has been successful in, and to make this as seamless and successful a process as we can. So what else has changed over the last 20 years? Neuroscience has taught us that our brains are still maturing at 18, 20, and up to age 25. And specifically the prefrontal cortex, the center that controls impulse control and decision-making and judgment. So just at the time when we're asking 18-year-olds and 19-year-olds to make complicated decisions about vocation and education and housing and transportation and their medical care, et cetera, it's not that they're not trying. Some of them don't have their hard drive yet, the ability to make these decisions. And so we have to take that into account. So caring for an adult with diabetes at 30 is different from caring for an adult with diabetes at 19. And those in the audience who care for young adults who are clinicians know what I'm talking about. Over the last 20 years, almost every major professional organization has recognized that they need to make statements, white papers, set this as a priority. The Society for Adolescent Medicine in the years that go along with this, the AAP consensus statement, the American Academy of Pediatric consensus statement, the American Heart Association, the American Diabetes Association, Child Neurology Foundation, and I could have a list of 20 more. And so I mentioned earlier about the relationship between pediatrics and adult medicine. This was a survey that was done in 2008, and this was family practice physicians. So what about the notion that they don't want to take care of young adults? Well, it's just not true with certain conditions. I was talking to Mary Ciccarelli, who's going to be our next speaker, and internists are very comfortable taking care of asthma and diabetes and hypertension, as demonstrated here. And about half of them, and remember this was 11 years ago, half of them were comfortable with behavioral conditions, mental health conditions. And they acknowledged that a minority of them were comfortable with things they simply hadn't had training in. Autism, cystic fibrosis, metabolic disorders, chromosomal disorders, relatively rare disorders. And those were technologically dependent. So yes, they were capable of taking care of complexity, but there needed to be some infrastructure bridge building between the two, and not let the patient family alone have to negotiate that bridge. And the American College of Physicians really stepped up and had been planning this for years, but in 2016, they developed disease-specific tools to assist physicians who are transitioning young adults with chronic conditions into their practices. This was in collaboration with Gut Transition, Society for Adolescent Health and Medicine, Society of General Internal Medicine, and there were over 20 participating organizations. So the adult community is invested in this as much as the pediatric community. We're one, it's one community. There's no us and them here. It's us. President Obama signed the Affordability Care Act in 2010, and when people would say to me, because it has been controversial, hey, Al, what do you think? Dr. Hergenroeder, what do you think of the ACA? I said overnight, hundreds of thousands of young adults and their families took a sigh of relief that was at least one less barrier that they had to wrestle down. There were many barriers, but this was one less barrier. And the notion that we would get rid of this is, I don't know the adjective that adequately describes what it would mean to families. It would be horrible for families to pull the rug out from underneath them. Now, this is not to say that those with public insurance have That's still very difficult. We struggle with this at Texas Children's. We struggle with this in our clinics. How do we afford the level of care for publicly insured patients who age out of CHIP and Medicaid, et cetera? We have to solve that problem. That is a challenge. But this was a sentinel act on behalf of families and youth and young adults with transition. And the Maternal and Child Health Bureau invested in a center. They said we have to have a cornerstone around which activities are going to be organized. And so they supported Got Transition, a National Healthcare Transition Center. Dr. White, Peggy McManus are here and represent what that center has meant to the field over 20 years. So there was an initial clinical report, 2001. The AAP stated a clinical report where they talked about medical home, office policy, transition plan. The chronic condition management model was suggested. There was an implementation of adult care model and transition. And this is what has emerged since then. Most of the presentations yesterday referred back to this process. No matter where you are in your building your program, this is something that you can refer to. This is Got Transition's way to say, hey, listen, we have a process, we have metrics, we have evaluation. You can take a look at this. Where you start is up to you. But they've established that this is a process. And so how has the field changed? Look at this compared to where we were 20 years ago. Night and day. Families as partners. When I started in the field over 20 years ago, families as partners were important, but they've become increasingly important and not in a peripheral way. They've driven a lot of policy. I mentioned Ivy Goldstein's quote earlier. When we stopped and listened to the people who really were the content experts, things started to get better in many regards. And if we're going to make progress over the next 20 years, we'll continue to strengthen these partnerships. And I love this quote because it encapsulates patient-centered care. Rather than asking how best to manage transition, physicians are trained to see problems, diagnose, treat, and solve the problem. Rather than asking how best to manage transition, we might ask how to best meet the needs of young people with diabetes or, in brackets, any other long-term condition at this stage of the life course. Transitioning into adulthood is a validation that the young adult has become an adult. When they stay in pediatrics, there's an implicit, and not all patients will be able to transition. We understand at Texas Children's, we see patients with rare conditions and for one reason or another may not be able to transition easily into adult care. I understand that. But for the vast majority of patients, this is a validation that we and them and their families and their providers are behind them. We're going to support them transitioning into adult care because they're also transitioning into housing, into transportation, into school, into vocation. So it's a validation of that process. The medical home has always been important, but it's become scientifically established that having a medical home is a predictor of the ability to transition. So we all call medical home a different place in different centers. It might be the subspecialist home, but it might also be the primary care provider's home, but it's where the information resides, where decisions can be made based on data. And that medical home has become fundamental to healthcare transition. It always has been, but increasingly it's been validated. And so over the last 20 years, from a personal point of view, what I've rediscovered, is the model laid out by Donna Beatty in 1966, where in response to the repeated query, why aren't we able to better treat diabetes or treat obesity or solve this process problem? Physicians would be asking because they see a problem, they want to solve it. Donna Beatty wrote a very influential paper that really became a cornerstone for the development of quality improvement, is that rather than looking at the outcome, successful transition, if you don't have structures in place to support the processes in place to process, you will never get to the satisfying outcome. And then the corollary of that is you have to evaluate the process. So for those of you who are in various stages of planning your program or refining your programs, this to me is a cornerstone of the way I think about it: structure, process, outcomes. So So let's go back to structure and process. So in 2004, we had a committee, and there were about 7 volunteers, myself, 2 or 3 other physicians, nursing, social work, child life, and an IT person. And we met monthly, and we were so excited about this. And we met monthly, and we kept rudimentary minutes. And we had subcommittees on insurance and professional education and education of families and building a transition planning tool. I mean, we left and we were so excited what we were going to do. And we got back together a year later and we said, okay, let's evaluate what we've done over the last year. We didn't accomplish anything. So we said, we can't do this. This is just, we can't. We're going to take one thing. We're going to build a transition planning tool, and we did. And it's in our EMR, and it's a prototype. But we also said to the administration, listen, this is a volunteer effort. This is what we're doing at lunch. This is what we're doing in the evenings and on the weekends. We can't do this. We need support. So we got support. We got 1 FTE. And all of a sudden, minutes were better. Meetings were more regular. We were doing technical assistance. Things were happening. And then we got a grant. And we got another grant. And then we had 2 full-time employees. And we had 3. And now we had people who weren't just coming to once a month meetings. They were on board, and we were working a lot in the middle. So now we have a robust process. So what we've learned over 20 years, what we've rediscovered over 20 years, is that if you don't put time and effort behind this, you're not going to have a transition program. So your administration can say to you, I really want you to do this, and then come back a year later and say, what have you done? Well, start with day 1. If you give me support, I'll deliver. But if I don't have support, I'm not going to be able to deliver. So have we found what works? This was a review by the Agency for Healthcare Research and Quality in 2014, and I cherry-picked a few of the studies. Yes, things do make a difference. 40% of patients with type 1 diabetes dropped out of care without a transition navigator versus 11% who had a transition navigator. So this was a strong study. The good thing was it suggested a transition navigator helps. So what did a lot of people do? They said, I'm going to have a transition navigator. So they went back and asked for an FTE transition navigator. But as we talked about yesterday, there were some comments in the session about it's not just, this is not piecemeal. This is a foundation, and then you add what your system needs. But not everybody needs a transition navigator. Not every disease process needs a transition navigator. Young adult diabetes clinic, and a lot of the research early on, the first 10 or 15 years, had to do with diabetes and some with cystic fibrosis. Hemoglobin A1C levels improved after 5 visits to an adult practice. Diabetic ketoacidosis rates dropped by 30%, challenging the notion that there's morbidity and mortality when they leave pediatric care to go to adult care. No. Care improves in many cases. In a randomized controlled trial, patients with type 1 diabetes, cystic fibrosis, inflammatory bowel disease had improved disease management after they transitioned. And a couple of others. Having the patient family meet with the adult provider in advance, there was evidence that that worked. In diabetes, joint ped med clinics, transition coordinators, after-hours phone support. So there were a lot of elements coming in that say this works, and a lot of it was in diabetes early and then in other disease processes. And in a systematic review that was referred to yesterday, and now there's an update that was presented yesterday as an abstract, Gabriel and Patience and Peggy are also authors on that. 28 out of 43 healthcare transition evaluation studies showed positive outcomes. 28 out of 43. And this was in the context of the triple aim. Maybe it was in population, maybe it was a population metric. Maybe it was in patient satisfaction, or both. And a few of them were in cost. But planning healthcare transition makes a difference. So the science is evolving. But this paper reminds me of just because you have science doesn't mean it's going to get implemented into practice. This was a paper that was written in 1986 by Gaston et al. It showed that prophylaxis with oral penicillin in children with sickle cell anemia was so successful in decreasing morbidity and mortality that they stopped the trial partway through because it was so successful. And Gary Freed, this was in 1986, Gary Freed, a colleague of ours, did a review of publicly funded clinics across the state of Michigan 20 years later, and tried to discern how often kids with sickle cell disease were getting oral prophylactic penicillin therapy. And it was less than 50% were getting prophylactic therapy. So the evidence was unequivocal that oral penicillin made a difference. So our challenge is to show what works. But an equally formidable challenge is going to be changing the culture. How do we implement this? And my sense is that implementation science is going to play an increasingly important role in what we do over the next 20 years. Quality improvement has really risen to the fore in terms of not waiting for randomized controlled trials to drive the field. We had a lot of QI presented yesterday at the Healthcare Transition Research Consortium meeting. 3 of the questions that QI asks are, what are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in an improvement? And one of the cornerstones of QI is Plan, Do, Study, Act, PDSA cycles. And many of the people in the audience have implemented this in their centers, and for us it's been a fundamental part of what we do in our research and program development, trying to change cultures in the process. So are we able to predict healthcare transition readiness? We have tools, and we have readiness measures. But one of the other things we've learned over the years is that if you're going to start a transition program, don't start by developing your own tool. That's going to take 2 or 3 or 4 years to find a tool, implement a tool, try to get it into your EMR. There are tools that are available. So go to the next step. Given you have an assessment method, what's the next step? How are you going to intervene whenever you find a patient or family is ready to transition or not ready to transition? So Schwartz did a review which showed 56 transition readiness measures. Some were generic and some were disease-specific. Some of them had psychometric properties, but none have been proven in terms of predictive validity for successful transition. And we had a paper presented yesterday where they looked at the Track 20 and how it would predict who would transition. And there were complications, or there were potential explanations as to why that relationship may not have been there. But nonetheless, we still have to make progress in being able to predict who's going to make progress in transition and who's not. And my sense is what's evolving is there's 1 or 2% of the most complex patients who are going to need the most resource support and case management and et cetera, et cetera. And then there's a medium complexity group that may need case management but maybe one step removed. And then patients with mild conditions who are not technologically dependent, who are developmentally normal, who have resources, who have commercial insurance. Those patients are probably going to transition reasonably well, but that's not to say we can't plan and shouldn't plan with them. The predictive value of transition planning tools is not known. So there's been a lot of work done in this area, but again, there isn't one metric that says, if you have this tool and this is what the score is, this is what's going to predict successful transition. In part, it's not a failure of the field, it's a reflection of how complex the determinants of successful transition are. So it's important, but it's not the single reason that's going to determine whether or not somebody's going to transition. And what is successful transition? If we listen to patients and families, they'll tell us what's important is quality of life. Yes, there's many other things that are listed here, but this is something that stands out. Achieving an optimal quality of life. So medical care and their medical condition is important to the extent that they have a quality of life. How are we doing with transition planning? If you look at the metric of the core transition outcome from HRSA and the Maternal and Child Health Bureau, we're not doing all that well. This is the number of youth with percentage of youth with special health care needs and the percentage of youth who do not have an identified special health care need who have met the core transition plan. There's 3 components to that by the time they are reaching adolescence or young adulthood. So what are our challenges? I should know this, but is somebody timing me? Thank you. What are our challenges? We have to define successful transition, and maybe there's not one definition, but to the extent that we can, we have to define what we're aiming for. To the extent that we achieve that, then we'll be able to refine our planning programs, our transfer programs, our safely landing an adult and getting integrated into adult care programs. How do we predict successful healthcare transition? My guess is over the next 10 years or so, we will refine this and maybe be a bit more precise. We have to follow the loss to follow-up problem. I know at Texas Children's, when we have patients who leave and they go to a variety of adult practices, when we had asked the pediatric providers, how are your patients doing 2 years later or 5 years later, there isn't a mechanism for many of the services to know how people have done. And if we're going to define our successful transition simply by 1 year post-transition, I think we're not doing justice to all the work that goes into planning transition. We need to follow up for 2 years or 5 years. So loss to follow-up is an issue. Professional training on the pediatric side to be better at planning transition, and professional training on the adult side to integrate these patients into their practice is needed. And there have been advances made, but we have a long way to go. We need policies. We need policies to improve, and I'm looking at some of our other speakers. We need policies to improve the interface, especially the education system and the medical system. So the education system has an easy conduit to what it is that we are saying patients can do and cannot do. And likewise, we need to know from an educational point of view that our patients are being well served. We need more research funding. Much of the research that was presented yesterday was because the people who were doing research had worked hard, had got 3-year grants or 1-year grants, and so they're going from one grant to the next. We need to increase funding at the federal level. We need to increase funding at the state level so some of these 3 to 5 year studies can take place so we can carry this follow-up out longer. And not listed here is that we need payment. We need to pay for, if we're going to change behavior on the pediatric side, if we're going to change behavior on the adult side, we need to pay for it. That's what's going to be important in changing behavior. And we need to continue our partnerships. So I'm especially thankful for one partnership I didn't mention in the beginning, but I saved it to this point, is we've had a very good relationship with our Texas State Title V agency, Lisa Walker, Rachel Drew, Amanda Hall, Carol Harvey, now Ivy Goldstein. Whenever we've had a question, we've given them a call. Whenever they've had a question, they've given us a call. It's been a great collaborative, reciprocal relationship. So I'm optimistic about the next 20 years. Why am I optimistic? For those of you who were here in 2003, we opened many of the conferences. When we transitioned from the art show, we transitioned to an artistic endeavor. And so this was 2003, and the Houston Downs Syndrome Mime Troupe mimed Dave Brubeck's Take 5. So who would have thought that was possible? Isabel Stenzel Burns is a patient with cystic fibrosis, and she wrote a book called The Power of Two. Excuse me. And it was a story of her sister and her with cystic fibrosis and how their family supported her and her sister. And they went to college and they got married and they both had lung transplants, and her sister passed away, and this was the first time she publicly talked about that and the publication of her book. And I was inspired by that. Her and her sister did not let their disease define them. And I'm inspired by Beth Suffian. She's the only person who has spoken here for 20 years, and she's been an inspiration from a professional point of view and from the point of view of somebody who has lived with a disease. And I'm inspired by Jake Olson. If you remember, 4 or 5 years ago, Jake Olson is blind. And he was a snapper in football. If you all know what that is, that's a guy that snaps the ball back to the place kicker. And so he went to University of Southern California and he told the coach that he had snapped in high school, and would he be willing to consider giving him a try on USC's football team, which was a top 10 football team. And they said, sure, let's give it a try. And so he actually got onto the field, snapped for an extra point, and then the conductor of the USC band gave him the baton, and he conducted the USC band. So who would have thought that was possible? And Allie Stoker. I'm inspired by Allie Stoker, who won the Tony for Best Actress in a Musical in 2019 for the new rendition of Oklahoma. And I'm inspired by Cody Lee, the America's Got Talent 2019 winner. He has autism, and yet at the piano, he's brilliant. So I'm inspired by all these people and by all that we've accomplished. So we're back to the gathering. We've come here for 20 years, and we've shared each other's frustrations, but we've also shared our successes. And it's been an honor to be with you, and even more so to be with the families, to a privilege to walk beside them and see their resiliency and their courage. And I can't wait to see, when we gather again, what we do next year and over the next 20 years. Thank you.